This lecture will cover diabetes pharmacology, both insulin and non-insulin agents. Looking at our learning objectives, we will differentiate and apply the therapeutic application, the routes of administration, mechanism of action, and primary and significant adverse effects of pharmaceutical agents in diabetes management. And you can see the list of agents here. Recognize and apply the goals for glycemic control and hemoglobin A1C in diabetes patients set forth by the ADA and AACE. Summarize treatment algorithms set by the ADA for type 2 diabetes. Compare the various preparations and administration of the different insulin forms. Recognize medications that cause hypoglycemia and hyperglycemia. List common adverse reactions and contraindications of oral hypoglycemic agents as well as insulin, and explain patient education strategies related to endocrine pharmacology to improve adherence to treatment plans and support optimal disease management. So let's start by looking at the big picture. What are we actually treating when we treat diabetes? There's two problems going on. First, we have hyperglycemia. In the short term, hyperglycemia causes symptoms: polyuria, polydipsia, fatigue, blurred vision. But in the long term, it increases risk for microvascular complications, things like retinopathy, nephropathy, and neuropathy, and contributes to macrovascular diseases like MI and stroke. Second, and equally important, there is cardiorenal risk. So many patients with type 2 diabetes do not actually die from glucose itself, but from things like atherosclerotic cardiovascular disease, heart failure, chronic kidney disease. And importantly, some therapies reduce cardiorenal risk independent of A1C lowering in diabetes management. So when we choose a therapy, we are not just chasing a number. We have to consider how elevated the patient's A1C is, what is the risk of hypoglycemia, what is the impact on the patient's weight, what is the patient's renal function, is there heart failure, chronic kidney disease, or atherosclerotic disease, and then of course cost and access, because none of this matters if the patient cannot afford it. So modern diabetes management is not just glucose-centered, it's also outcome-centered. Before we go class by class, let's quickly orient ourselves with the landscape of diabetes pharmacology. So broadly, we divide medications into insulin and related therapies and non-insulin glucose-lowering agents. Under insulin and related therapies, we have insulin itself, which we divide into rapid, short, intermediate, and long-acting forms. Amylin agonists like pramlintide and glucagon, which is not for lowering glucose, but for rescue hypoglycemia. Then we have our non-insulin agents. Metformin, our biguanide, is typically first line in type 2 diabetes. Sulfonylureas and meglitinides we use to stimulate insulin secretion. Our TZDs improve insulin sensitivity. Alpha-glucosidase inhibitors slow carbohydrate absorption. GLP-1 receptor agonist, also called incretin mimetics, enhance glucose-dependent insulin release. DPP-4 inhibitors prolong endogenous incretin activity. And our SGL2 inhibitors promote urinary glucose excretion. So try to think of each class not as a name to memorize, but as a mechanism targeting a specific pathway defect in diabetes: secretion, resistance, absorption, or excretion. And throughout the lecture, we'll break each of these down one by one. So let's define a few terms that we will see over and over throughout the lecture and in practice. A1C. So hemoglobin A1C reflects approximately 3-month average blood glucose, but it is heavily weighted toward the most recent 4 to 6 weeks. So it gives us a big picture view of glycemic control. Next, we have our fasting plasma glucose, or FPG. This primarily reflects hepatic glucose output, meaning how much glucose the liver is producing overnight. If fasting glucose is elevated, we often think about basal insulin or medications that suppress hepatic glucose production. Then we have postprandial glucose, or PPG. This reflects meal-related spikes. So if a patient's A1C is elevated despite normal fasting numbers, post-meal excursion may be the problem. And then on our insulin terminology, you'll hear the term basal insulin. This covers for fasting glucose. It provides background insulin throughout the day and night. Bolus or prandial insulin covers meals and correction doses, so it targets postprandial glucose spikes. When adjusting therapy, we always ask, is the problem a fasting glucose problem, postprandial, or is it both? And that determines whether you adjust basal, bolus, or add a non-insulin agent. Now let's talk about glycemic targets according to the ADA for most non-pregnant adults. For many patients, the general A1C goal is less than 7%. That level has been shown to reduce microvascular complications. For glucose numbers, fasting or pre-meal glucose should be between 80 and 130 milligrams per deciliter. 2-hour postprandial glucose should be less than 180. But, and this is critical, these targets must be individualized. So less stringent goals, such as an A1C under 8, may be appropriate in patients who are older, frail, have limited life expectancy, or are high risk for hypoglycemia. In those patients, avoiding hypoglycemia is often more important than tightening the control. More stringent targets, such as the A1C under 6.5, may be reasonable in younger, healthier patients who can achieve this safely without having a risk of hypoglycemia. So the right A1C is not the lowest possible A1C for all patients. It's the safest achievable A1C for that individual patient. Now let's discuss the AACE targets. That's the American Association of Clinical Endocrinologists. Often they favor slightly tighter glycemic control when it can be achieved safely. For appropriate patients with low hypoglycemia risk, the AACE may recommend an A1C of 6.5 or lower. However, similar to ADA guidance, if the patient has high hypoglycemia risk, multiple comorbidities, or limited life expectancy, then a more relaxed target between 7 and 8% is reasonable. So I want you to avoid getting lost in minor numeric differences between ADA and AACE. The key principle is that targets must be individualized based on safety, comorbidity, and hypoglycemic risk. So generally, clinical Pearl exams and practice, the safest patient-centered target is almost always the correct answer. So when is hyperglycemia an emergency? Not all hyperglycemia is routine outpatient management. Sometimes it becomes an emergency. So red flags that should prompt urgent evaluation include polyuria and polydipsia accompanied by weight loss and vomiting. That constellation should immediately make you think about possible diabetic ketoacidosis, especially in type 1 diabetes, but it can occur in type 2 diabetes as well. If the patient appears dehydrated, has tachypnea with Kussmaul respirations or altered mental status, that's no longer routine hyperglycemia, that's a potential metabolic emergency. You'll often see a random glucose level over 300 or 400 milligrams per deciliter in symptomatic patients. If ketones are positive, especially with symptoms, you must consider DKA. So numbers alone do not determine urgency. Symptoms plus metabolic instability do. So if a patient looks sick, think beyond outpatient medication adjustment. So let's walk through the core concept of the ADA treatment algorithm for type 2 diabetes. So step 1, in most patients, it is lifestyle modification plus metformin, assuming there are no contraindications. Metformin remains foundational therapy because it lowers A1C, has a low hypoglycemia risk, is weight neutral or possibly modestly weight reducing, and it's inexpensive. Step 2 is where modern management becomes more nuanced. So we now choose additional agents based on comorbidities, not just A1C. So if a patient has an established ASCVD or high cardiovascular risk, we add a GLP-1 receptor agonist or an SGLT2 inhibitor with proven cardiovascular benefit. If a patient has heart failure, SGLT2 inhibitors are preferred. If a patient has chronic kidney disease, SGLT2 inhibitors are also preferred, or a GLP-1 receptor antagonist antagonist if the SGLT2 inhibitors are not tolerated. And importantly, if a patient's A1C is very high and they are symptomatic with hyperglycemia, then we would consider insulin early rather than stepping slowly through the above oral agents. So the algorithm is no longer glucose only, it's glucose plus organ protection. And then an important thing to point out here is that insulin, as we said on the previous slide, is not just for type 1 diabetes. There are clear situations in type 2 diabetes where insulin should be started early. You should consider insulin if the A1C is 10% or higher or significantly above goal despite oral therapies. At that level, oral or non-insulin injectables alone are insufficient. If the patient has a glucose of 300 milligrams per deciliter or higher, that's another strong signal that insulin may be necessary. More importantly, look for catabolic symptoms, so unexplained weight loss, ketosis, signs of insulin deficiency. That suggests the body is breaking down fat and muscle due to inadequate insulin action. So also if the patient has symptomatic hyperglycemia, so things like significant polyuria, polydipsia, fatigue, insulin may provide faster control and symptom relief. Finally, if a patient has failed appropriate non-insulin combinations, insulin then becomes the next logical step. So starting insulin is not a sign of failure, it's an appropriate escalation when physiology demands it. So we're going to move through some of the foundations of how insulin works and what it does. First, what does insulin actually do physiologically? So insulin increases glucose uptake in muscles and adipose tissue. This allows glucose to move from the bloodstream into cells for energy or storage. Second, insulin decreases hepatic glucose production. So our liver is constantly producing glucose through gluconeogenesis, especially overnight. Insulin suppresses that process, which is why basal insulin helps control fasting glucose. Third, insulin promotes glycogen, fat, and protein synthesis. It's an anabolic hormone, and that is why weight gain can occur with insulin therapy. We are promoting storage. And finally, this is, and clinically important, insulin drives potassium into the cells. This is why insulin is used in the acute treatment of hyperkalemia. By shifting potassium intracellularly, serum potassium levels temporarily decrease. Insulin does not just lower glucose. It is a metabolic regulator affecting glucose, fat, protein, and potassium balance. So how are we delivering insulin? In the outpatient setting, insulin is most commonly administered subcutaneously using either a pen or a syringe. Pens are increasingly preferred because they improve dosing accuracy and adherence. Insulin pumps deliver continuous basal insulin with programmed bolus dosing at meals. So pumps more closely mimic physiologic insulin delivery and are common in type 1 diabetes. When we move into the inpatient setting, especially in the ICU or during DKA, we use IV insulin, which allows rapid titration and close monitoring. And then let's talk about the technique, because technique errors are common when administering insulin. So when a patient is giving themselves injections, they have to rotate injection sites. Repeated injections of the same area can cause lipohypertrophy, which is a localized fat accumulation. This also impairs insulin absorption if they continue to use the same site, and that will lead to unpredictable glucose control. Storage is important. Unopened insulin should be refrigerated. Once in use, many products can be kept at room temperature for a specified amount of time, but students should always check in the product insert. Finally, the needle length and injection angle matter because we have to ensure that we're delivering this medication to the subcutaneous area, avoiding intramuscular injection, which would alter absorption. So when glucose control is erratic, always talk to the patient about the technique they're using before you adjust the dose. So let's organize insulin into some big functional categories. This classification is pretty high yield for exams and for clinical dosing decisions. So first we have our rapid acting insulin. That would be Lispro, Aspart, or glulicine. These are used for mealtime coverage and correction dosing. So they act quickly and are designed to match postprandial glucose spikes. Then we have our short-acting insulin, which is called regular insulin. Regular insulin has a slower onset than rapid-acting insulin and historically was used for mealtime coverage. It's still used in certain inpatient settings and in IV insulin protocols. We then have intermediate-acting insulin, which is known as NPH. NPH has a noticeable peak and is typically dosed twice daily. It is less physiologic than long-acting insulin and has a higher hypoglycemia risk due to its peak. Finally, we have our long-acting or basal insulin, so that's glargine, detamir, degludec. These provide kind of a steady background insulin coverage. They are primarily used to control that fasting glucose and suppress hepatic glucose output, again, largely overnight. When you see fasting hyperglycemia, you're going to think of basal insulin. When you see post-meal spikes, you're going to think of your rapid-acting insulin. So we're going to get a little more specific on each of our classes. So our rapid-acting insulin, this includes Lispro, Aspart, and glulicine. These are your prandial insulins, meaning they're designed to cover meals. They have an onset of about 10 to 20 minutes, so they begin lowering glucose fairly quickly after the injection. They peak at approximately 1 to 3 hours, which corresponds to the time when post-meal glucose typically rises the most. And then their duration is about 3 to 5 hours. So they primarily cover the meal and a short correction window. We use the rapid-acting insulin as, again, meal insulin and for correction dosing, meaning if a patient's glucose is elevated before a meal, we add additional units based on a correction scale. So best practice is to give rapid-acting insulin with meals or immediately after if you're uncertain how much the patient will eat. This is especially important in hospitalized or pediatric patients to avoid hypoglycemia if intake is unpredictable. So if rapid-acting insulin is given and the patient does not eat, hypoglycemia would be, of course, the predictable complication. So our short-acting insulin refers to regular insulin compared to rapid-acting. Regular insulin has a slower onset, 30 to 60 minutes. So that means it has to be administered earlier before a meal. Typically, this will peak about 2 to 4 hours, and its duration is longer, roughly 5 to 8 hours. Clinically, regular insulin may be used as mealtime insulin when cost is a barrier, because typically this would be less expensive than rapid-acting analogs. This type of insulin is also used intravenously in DKA protocols in inpatient settings because you can give this IV and titrate it quite precisely. The key difference is timing. Because regular insulin acts more slowly, it must be given about 30 minutes before a meal. If it's given too close to the meal or if the patient eats later than expected, hypoglycemia can occur later when that insulin peaks, but the glucose intake has already declined. So rapid-acting insulin matches physiology better. Regular insulin works, but timing errors increase the hypoglycemia risk. Intermediate-acting insulin refers to NPH. NPH has an onset of about 1 to 2 hours, so it does not work immediately. It has a significant peak between 4 and 12 hours, and its total duration is roughly 12 to 18 hours. So historically, NPH was used for basal coverage in older insulin regimens and is often dosed twice daily to provide that 24-hour coverage. The key issue with NPH is that it does have that very pronounced peak, and that peak increases the risk of hypoglycemia, particularly if the timing of a meal does not match the insulin action. So when given in the evening, that peak can occur overnight, which is why nocturnal hypoglycemia is a known risk for NPH. This is also a reason that long-acting basal analogs have largely replaced NPH in many patients. They provide a flatter, more predictable coverage. So if a patient is reporting waking up shaky at 3 o'clock in the morning, we are thinking about peaking insulin like NPH. So let's look at our long-acting or basal insulins, glargine, detamir, and degludec. The goal of basal insulin is to provide steady background insulin with minimal peak. So unlike NPH, these agents are designed to have a flatter profile, which reduces that hypoglycemia risk. So basal insulin primarily controls fasting glucose because it suppresses that hepatic glucose production that occurs overnight. In type 2 diabetes, basal insulin is often the foundation when we initiate insulin therapy. In terms of duration, glargine lasts about 24 hours and is typically given once daily. Detamir is about 12 to 24 hours and may be required to go to twice daily dosing in some patients. And then degludec lasts longer than 24 hours and it offers very flexible dosing due to its ultra long duration. The key clinical difference is predictability and hypoglycemia risk. So degludec, for example, has a very stable kinetic and a lower nocturnal hypoglycemia risk. If fasting glucose is elevated, but post-meal values are reasonable, the adjustment should target basal insulin, not add more mealtime insulin. So that's kind of like a clinical pearl now that we've seen all of our options for insulin therapy. So let's review and compare all of our options in kind of a practical way. So again, our rapid-acting insulins best for mealtime coverage. They closely match physiologic insulin release and have less delayed hypoglycemia because their duration is shorter. Regular insulin is cheaper and is still effective, but it has that delayed onset and a longer tail. And that longer duration increases the risk of late hypoglycemia if meal timing is inconsistent. NPH, also very inexpensive, but has that pronounced peak. And that peak increases hypoglycemia risk, especially overnight, which makes it less predictable than our basal analogs. And then finally, our basal analogs, like glargine, have that smoother profile, lower hypoglycemia risk, but they are typically more expensive. So this brings us to the real world prescribing. In practice, cost and insurance will often determine what the patient can actually receive. The safer drug on paper is meaningless if the patient cannot afford it. So always ask your patient, always kind of ask yourself, what is ideal and what's realistic and acceptable for your patient? And that question will sometimes change the regimen that you end up going with. So let's quickly talk about how insulin is typically introduced and intensified in type 2 diabetes in a primary care setting. So the usual progression is to add basal insulin at night. As we said before, this targets fasting glucose first because hepatic glucose output overnight is often the major contributor to the elevated A1C. So once basal insulin is started, we titrate based on fasting glucose. And that's key. The basal insulin adjustments are driven by fasting values, not postprandial readings. If the patient is still above their A1C goal despite optimizing the fasting glucose, we have then two main next steps. Number one option is to add a GLP-1 receptor agonist, especially if weight loss or cardiovascular benefit is desirable. And then another option is to add a prandial insulin with the largest meal, often called a basal plus strategy. And this targets the post-meal spikes, post-meal spikes without immediately committing to full basal bolus therapy. And if needed, we then progress to basal bolus therapy. And that would be adding rapid-acting insulin before multiple meals. So clinically, we try to fix the fasting first with a basal approach. If A1C remains elevated, the problem is typically postprandial glucose, and then we have a strategy to address that. Let's look at our insulin adverse effects. So by far the most important and most dangerous is hypoglycemia. This can range from a patient feeling mildly shaky and sweaty to confusion, seizures, loss of consciousness. So most insulin-related harm is going to come from hypoglycemia rather than hyperglycemia. Second is weight gain. This is very common, remembering that insulin is an anabolic hormone to promote glycogen and fat storage, and improves glycemic control by reducing glycosuria, meaning fewer calories are lost in the urine. We also see injection site reactions. Typically, these are mild, lipohypertrophy that can occur when a patient repeatedly injects in the same area. And so that's that fat accumulation. It leads to kind of the erratic insulin absorption. So making sure to rotate the sites is critical. Some patients can develop insulin edema, usually when starting therapy or after a rapid improvement in glycemic control. What's key here is that most insulin harm comes from hypoglycemia. Every patient has to be taught how to recognize the symptoms, sweating, tremor, confusion, how to treat it with rapid-acting carbohydrates, and how to prevent it by matching insulin to food and activity. So if a patient has recurrent hypoglycemia, the answer is almost never more insulin. It's dose adjustment and patient education. So because hypoglycemia is the most important risk of insulin therapy, we need to recognize it early and clearly. We got two main categories of symptoms. So we have our autonomic symptoms. These are caused by activation of the sympathetic nervous system. These include sweating, tremor, palpitations, hunger, anxiety. They are often the early warning signs. And then second is our neuroglycopenic symptoms, which occur when the brain is not receiving enough glucose. These include confusion, slurred speech, behavioral changes, seizures, even coma. These are later and obviously very dangerous signs. And what are some of the risk factors? So missed meals are, of course, the most common. If insulin is given, but the carbohydrate intake does not match, that's going to lead to hypoglycemia. Excessive insulin dosing, of course, will increase the risk. Alcohol is important because it impairs hepatic gluconeogenesis, so the liver cannot release glucose effectively. Renal impairment reduces insulin clearance, so that can prolong its action. Exercise increases glucose utilization, so insulin doses have to be adjusted with increased physical activity. So we have these early autonomic symptoms that are a warning. If a patient ignores these signals, neuroglycopenia will follow. So we have to teach the patient to treat early, not late. So when we treat hypoglycemia, we follow the 15-15 rule. If a patient is conscious and able to swallow, that is where this rule applies. So we give 15 grams of fast-acting carbohydrates. So that might be something like a glucose tablet, orange juice, or regular soda, and then recheck the glucose in 15 minutes. If the glucose remains low, we give another 15 grams. Once you have a normalized glucose, if the next meal is not soon, then the patient should eat a longer acting carbohydrate with protein. So peanut butter with crackers, something that combines the, again, longer acting carb and the protein to prevent recurrence. Now, if the patient is severely hypoglycemic or unconscious, oral treatment is obviously not appropriate. In the outpatient setting, that is where we administer Glucagon IM or intranasally as rescue therapy. In the hospital, we give IV dextrose, which works very rapidly. So you would never give oral carbohydrates to an unconscious patient, obviously, because airway protection always comes first. And every patient on insulin should have a hypoglycemia action plan. So glucagon is rescue therapy for severe hypoglycemia, specifically when a patient is unable to take anything by mouth. For example, if they're unconscious, they're seizing, or they're unable to swallow safely. In the outpatient setting, we can administer this glucagon through IM injection using a kit or as intranasal glucagon, which has made administration very simple for caregivers. If we look at the mechanism, glucagon works by stimulating hepatic glycogenolysis. It signals the liver to break down stored glycogen into glucose, so that raises blood sugar. There are some limitations here. Glucagon is less effective if glycogen stores are depleted, such as a patient that's had prolonged starvation, severe malnutrition, heavy alcohol use, because alcohol impairs that hepatic glucose production. And so that's critical. It's not enough for the patient to just know about glucagon. Family members, roommates, teachers, caregivers must know how to use it. In an emergency, the patient will not be able to self-administer. So if a patient is on insulin or a medication that can cause hypoglycemia risk, ask yourself, does someone close to them know how to administer glucagon for them? So insulin is classified as a high alert medication, and many severe adverse events result from preventable errors. So one common error is confusing units and zeros in documentation. So writing 10U can be misread as 100. Clear documentation, writing out units reduces this risk. So dose clarity is very critical. Another major error is mixing up insulin types, especially rapid acting and long acting. Giving rapid acting instead of basal or vice versa can result in severe hypoglycemia or uncontrolled hyperglycemia. We have to pay attention to the syringe concentration, particularly U100 versus U500 insulin. Using the wrong syringe or misunderstanding the concentration can lead to obviously like a 5-fold dosing error. Another dangerous behavior is stacking correction doses. So something called chasing a high, a rapid acting insulin lasts for 3 to 5 hours. Giving additional correction doses before prior insulin has finished working can cause a delayed hypoglycemia. And then finally, expired or overheated insulin obviously would reduce the potency. That would lead to unexplained hyperglycemia. So always make sure the patient understands storage and expiration. Anytime you have erratic glucose control, think about these errors before assuming that the treatment is failing. So insulin problems often come down to technique and dosing, not disease progression. So insulin education is not an optional item. It is a safety requirement. First of all, we have to demonstrate the injection steps and site rotation. So you don't ever assume that your patient understands after verbal explanation alone. You have to show them how to draw up or dial the dose to inject subcutaneously and to rotate sites to prevent lipohypertrophy and the erratic absorption that will result. And then secondly, we need to clearly explain the timing with meals. So rapid acting should be given with meals. Regular has to be given earlier, about 30 minutes before. Timing errors, remember, are one of the most common causes of hypoglycemia. Third, we got to review that proper storage. So unopened insulin typically has to be refrigerated. Insulin in use can usually be kept at room temperature for a specific time, but again, you want to follow the product guidance. Patients have to know when to call their provider. So if they're seeing recurrent episodes of hypoglycemia or hyperglycemia, they feel ill, they're vomiting, or they're noting positive ketones, then they need to let us know. And then we will teach the sick day rules. Most importantly, patients with type 1 diabetes should never stop that basal insulin, even if they are not eating. So stopping basal insulin can rapidly precipitate DKA. So good insulin prescribing includes very good insulin teaching. And so poor education is a setup for preventable harm. Okay, let's look at some of our non-insulin diabetes pharmacology. So our biguanides, metformin is the prototype and cornerstone of type 2 diabetes therapy. It belongs in the biguanides class, and for most patients without contraindications, this would be first line for type 2 diabetes. Mechanism of action, it primarily works by decreasing hepatic gluconeogenesis. Remember, the liver produces that glucose overnight, so by suppressing that output, metformin lowers the fasting glucose. It also increases peripheral insulin sensitivity, meaning muscle tissue becomes more responsive to insulin. Additionally, it slightly decreases intestinal glucose absorption, though that effect is less clinically dominant. So our primary clinical effect is the reduction of fasting glucose and an A1C decrease of approximately 1 to 1.5%, which is quite substantial for a single agent therapy. So when fasting glucose is elevated, metformin directly targets the liver, which is often the central problem in early type 2 diabetes. So metformin is considered, like I said, first line in type 2 diabetes unless there is a contraindication. This is also used in certain patients with pre-diabetes, particularly those at high risk of progression, and is commonly used off-label in PCOS because of the insulin sensitizing effect. Let's talk a little more about why it's so widely used. So metformin is generally weight neutral or associated with mild weight loss, which is important because many diabetes medications promote weight gain. It carries a low risk of hypoglycemia when used alone, since it does not stimulate insulin secretion. There is evidence suggesting that there is a possible cardiovascular benefit, which further supports its role as foundational therapy. And most importantly, it's inexpensive, so that makes it very accessible to our patients. One important clinical point is that metformin is often continued even when insulin is added, because, as we said, it improves that insulin sensitivity and may reduce the total insulin requirement. So metformin works on the liver, improves insulin sensitivity, does not cause hypoglycemia, and is affordable. And that combination is why it remains really the backbone of type 2 diabetes management. So generally, metformin is very well tolerated. Let's look at some of the adverse effects that we will counsel patients about. So most common is GI symptoms, nausea, diarrhea, bloating, abdominal pain. These are dose-related and often improve over time. So starting low and titrating slowly helps minimize these effects. Taking metformin with food also improves the tolerance. There is a serious but rare complication, which is lactic acidosis. This is uncommon, but the risk will increase in patients with significant renal failure or conditions causing hypoxia or poor tissue perfusion. And then that leads us to our contraindications. It is contraindicated if the GFR is less than 30 millimeters per minute. At that level, the risk of accumulation increases. It should also be held during acute illness, because any acute illness is going to cause hypoxia or dehydration, such as infection or sepsis. And then it should also be temporarily held around when a patient is having iodinated contrast studies, especially in patients with reduced renal function due to the risk of acute kidney injury. So metformin overall very safe in stable patients, but always reassess if there's an acute illness or a renal decline. And the 6-day hold is an important patient education point. Let's look at sulfonylureas. These are our insulin secretagogues, meaning they stimulate the pancreas to increase insulin. Our examples are glyburide, glipizide, glimepiride. Mechanism of action, they work by closing potassium channels in pancreatic beta cells. When those potassium channels close, the cell depolarizes and calcium channels open, and insulin is released. The key point is that insulin secretion is glucose independent. So these drugs stimulate insulin release whether glucose is high or low. So clinically, they lower both fasting and postprandial glucose because they increase overall circulating insulin. Because insulin release is not glucose dependent, hypoglycemia is a major risk, particularly in elderly patients if they have irregular eating patterns or those with renal impairment. Glyburide is especially associated with prolonged hypoglycemia and is generally avoided in older patients. So if you see unexplained hypoglycemia in an older patient, always check if they are on a sulfonylurea. The two major adverse effects of sulfonylurea are hypoglycemia and weight gain. Hypoglycemia, as we said, occurs because these medications stimulate insulin secretion regardless of glucose level. So if a patient skips a meal or has a reduced intake, insulin is still being released. Weight gain occurs because increased circulating insulin promotes that fat storage. So remember, our insulin is an anabolic hormone. Certain populations are going to be particularly at risk. Our older adults, of course, more vulnerable because they have reduced renal clearance. They may have irregular eating patterns, and they may not recognize the early hypoglycemic symptoms. Patients with renal impairment, particularly with glyburide, have active metabolites that may accumulate. And patients, in general, if you have a patient that works and maybe cannot eat regularly, they're going to be a little too vulnerable likely for this medication because, again, the insulin is stimulated, but they may not be getting the food to level that out. So sulfonylureas, effective and inexpensive, but they are not very forgiving. So if the patient's eating schedule is unpredictable, this class would be likely too dangerous to use. For meglitinides include rapaglinide and metaglinide. Mechanism of action similar to the sulfonylureas. They stimulate insulin secretion by affecting the potassium channels in pancreatic beta cells. However, these are shorter acting. Because they're a shorter duration, they're primarily used for postprandial glucose control. They are taken with meals. if the meal is skipped, they just skip the dose. And that flexibility is going to reduce the prolonged hypoglycemia risk. So compared to sulfonylureas, our meglitinides have lower risk of hypoglycemia, largely because they can control the risk and they can adjust if they skip a meal. However, one downside is that, of course, the patient has to take this multiple times a day with each meal. That can create some adherence challenges, especially if a patient already struggles with medication timing. They can be useful for those patients we talked about that might have an irregular meal schedule due to work. And these are generally used less frequently because of our newer agents that are offering better A1C reduction, weight benefit. But if you think of your meglitinides as your shorter acting sulfonylurea, they're a little more flexible, less hypoglycemia, but more dosing burden. So let's look at our TZDs, which are pioglitazone and rosiglitazone. Mechanism of action differs from our secretagogues. The TZDs work by activating the PPAR gamma, which is a nuclear receptor that regulates gene transcription. By doing this, they increase insulin sensitivity in muscle and adipose tissue, so they help the body respond better to its own insulin. Their primary effect is reducing insulin resistance, which is a core pathophysiologic defect in type 2 diabetes. But one thing about their mechanism of action is that this causes them to work more slowly. So because they act through gene transcription, their glucose lowering effect develops over weeks, not days, and so they are not used for acute glucose control. So while they improve insulin sensitivity, the TZD's adverse effect profile sometimes limits the use, most commonly weight gain and edema. Because these agents promote fluid retention, patients may notice swelling, particularly in the lower extremities. That fluid retention leads to an important safety concern, heart failure exacerbation. So TZDs can worsen or precipitate heart failure due to that volume expansion. There is an increased risk of fracture, especially in women, likely related to the effects on bone metabolism. And because of these risks, TZDs are contraindicated in patients with symptomatic heart failure. They should be avoided in active liver disease because they are hepatically metabolized and can affect liver function. So important clinical pearl is, although the TZDs address insulin resistance, which is central to type 2 diabetes, safety concerns significantly limit their routine use in our modern practice. Alpha-glucosidase inhibitors include acarbose and miglatol. These medications work locally in the gut, so their mechanism is to delay carbohydrate absorption by inhibiting enzymes that break down complex carbohydrates in the small intestines. So because of this, their primary effect is lowering postprandial glucose. So they're going to blunt that spike that occurs after a meal. They do not significantly affect fasting glucose. The main limitation of this class is the GI adverse effects. So because carbohydrates remain in the gut longer and are fermented by bacteria, patients commonly experience flatulence, diarrhea, and abdominal pain. These often limit the tolerability and the long-term use. So if a patient has isolated post-meal spikes and prefers oral therapy, this class can work, but you have to counsel the patient about the GI side effects. So pramlintide is an amylin agonist. Amylin is a hormone that is normally co-secreted with insulin from the pancreatic beta cells. So in patients with diabetes, amylin secretion is deficient, especially in type 1 diabetes. Mechanistically, pramlintide works by decreasing glucagon secretion, slowing gastric emptying, and increasing satiety, so making a patient feel more full after eating. By slowing the gastric emptying and suppressing glucagon, it reduces that postprandial glucose spike. So clinically, pramlintide is used as an adjunct to insulin in both type 1 and type 2 diabetes. However, important safety point that when this is added to insulin, it increases the risk of hypoglycemia, especially early in therapy. So insulin doses have to be reduced when starting pramlintide. Because it requires additional injection and careful titration, it is less commonly used than our newer agents like our GLP-1 receptor agonists. So if you add pramlintide to insulin and you don't reduce the insulin dose, hypoglycemia is going to be very likely. So before we talk about our GLP-1 based therapies, we have to understand incretin physiology. Incretins, primarily GLP-1 and GIP, are hormones released from the gut in response to meals. So when you eat, incretins are released and they do several important things. First, they increase glucose-dependent insulin secretion. So that phase is critical. Insulin release increases only when glucose is elevated. Second, they decrease glucagon secretion, which reduces hepatic glucose production. Third, they slow gastric emptying, meaning glucose enters the bloodstream more gradually. And fourth, they promote satiety, which can reduce caloric intake. So this physiology explains why the GLP-1 based therapies lower glucose with relatively low hypoglycemic risk, because insulin release is glucose dependent. If glucose is normal, insulin secretion is not stimulated. The phrase glucose dependent should immediately signal lower hypoglycemia risk compared to, for example, your sulfonylureas. GLP-1 receptor agonists, so this is going to include your semaglutide, liraglutide, and dulaglutide. These medications mimic endogenous GLP-1, so mechanism is they stimulate glucose-dependent insulin release. They suppress glucagon, they slow gastric emptying, and they increase satiety. Because insulin release is glucose dependent, again, our hypoglycemia risk is low, especially when used alone. So in terms of benefit, they lower the A1C by approximately 1 to 1.5%, which is, of course, comparable to metformin. They also promote weight loss, which is a major advantage in type 2 diabetes management. And importantly, select agents in this class have demonstrated a cardiovascular benefit, which is why they are recommended in patients with established ASCVD. Most GLP-1 receptor agonists are injectable, given either daily or weekly. However, there is an oral formulation of semaglutide which expands the options for patients who prefer not to inject. Overall, GLP-1 agonists are not just glucose-lowering drugs, as I'm sure you have heard if you have seen any media coverage. They are weight-reducing and cardioprotective agents in the right patients. The most common adverse effects of GLP-1 receptor agonists are GI. Patients frequently experience nausea, vomiting, diarrhea, especially when they first start the therapy and when the dose is increased. So these symptoms are related to, of course, the slowed gastric emptying and central satiety effects. Nausea often improves over time, so you can counsel the patient on that, but that is why we start low and we titrate slowly. There are rare but serious adverse effects to be aware of. Pancreatitis has been reported. Though uncommon, patients should be instructed to report that severe persistent abdominal pain. There's also an association with gallbladder disease, likely related to that rapid weight loss. In terms of contraindication, the GLP-1 receptor agonists are contraindicated in patients with a personal or family history of medullary thyroid carcinoma or MEN2 syndrome due to findings in animal studies suggesting that C-cell tumor risk. So most patients tolerate the GLP-1s very well if it is titrated gradually. And again, that early nausea is common, but persistent severe abdominal pain is not, and so that needs to prompt early evaluation. DPP-4 inhibitors include sitagliptin, saxagliptin, and linagliptin. Mechanism: these medications work by inhibiting the breakdown of endogenous incretins, particularly GLP-1. So instead of mimicking GLP-1 like the injectables, they prolong the action of the body's own incretin hormones. Because incretin activity is glucose dose dependent, DPP-4 inhibitors also carry a very low risk of hypoglycemia when used alone. In terms of benefit, they are weight neutral, which is an advantage compared to the sulfonylureas, of course. However, their main limitation is modest efficacy. So they reduce the A1C by approximately 0.5 to 0.7%, which is less than metformin or a GLP-1 receptor agonist. Because of the modest activity, they're often used in patients that just need a little mild additional control and want an oral option with good tolerability. So you think of your DPP-4 inhibitors as the gentler incretin option. They are convenient and well tolerated, but obviously less potent than our GLP-1 receptor agonist. So as we said, these are generally very well tolerated. Our common adverse effect include nasopharyngitis and headache, which are usually fairly mild. Rarely pancreatitis was reported, similar to the GLP-1 receptor agonist, though the overall risk is low. Patients obviously should be counseled about that severe persistent abdominal pain. So key clinical takeaway is that the DPP-4 inhibitors are less potent than the GLP-1 receptor agonist in terms of A1C reduction and weight effects. However, they are oral, weight neutral, and well tolerated, which can make them more appealing. If you need strong A1C reduction and weight loss, you have to choose the GLP-1 receptor agonist. If you need a simple oral agent with low hypoglycemic risk and a modest effect, a DPP-4 inhibitor may be the right fit. SGLT2 inhibitors include anything with the glioflozin at the end of the name, so empagliflozin, dapagliflozin, canagliflozin. Mechanism: these drugs work in the kidney. They block glucose reabsorption in the proximal renal tubule, specifically at the sodium glucose cotransporter 2. So by blocking reabsorption, they increase urinary glucose excretion, essentially allowing the patient to urinate excess glucose out. This insulin-independent mechanism is important because it works even when insulin resistance is present. So in terms of benefit, our SGLT2 inhibitors promote modest weight loss since calories are being lost through glycosuria. They also can reduce blood pressure, likely due to the osmotic diuresis that occurs. Importantly, certain agents in this class have demonstrated cardiovascular and renal protection, including reduced progression of chronic kidney disease and reduced heart failure hospitalizations. So if a patient has heart failure or chronic kidney disease, think SGLT2 inhibitor, even beyond the glucose lowering effects. The most common adverse effects of the SGLT2 inhibitors are related to increased glucose in the urine. Because they promote that glycosuria, patients are at increased risk for genital mycotic infections, particularly candidal infections. This is more common in women, but can occur in men as well. They can also cause volume depletion due to the osmotic diuresis. So patients can experience dizziness or orthostatic symptoms, especially older patients or already on diuretics. Rare but serious complication is euglycemic diabetic ketoacidosis. So this is a situation where a patient develops DKA, but glucose levels may not be dramatically elevated, which can delay recognition. Our SGLT2 inhibitors are generally avoided in severe renal impairment since their mechanism depends on kidney function. From a counseling perspective, patients should be advised that hydration and genital hygiene can reduce the infection and adverse event risk. These medications should be held during any acute illness, surgery, periods of reduced oral intake to reduce that risk of DKA. And if a patient is on an SGLT2 inhibitor and they present with nausea, abdominal pain, malaise, even with only a mildly elevated glucose, again, you got to think about that euglycemic DKA. Okay, we're going to review some of the high yield concepts in diabetes management. So let's quickly look at some of the medications that can cause hypoglycemia. So our high risk medications are again the insulin, the sulfonylureas, and the meglitinides. Moderate risk is pramlintide, especially with insulin. And then our low risk medications for hypoglycemia are metformin, GLP-1s, DPP-4 inhibitors, and our SGLT2 inhibitors. And what about the reverse? What are some medications we have to worry about that can increase the level of glucose or cause hyperglycemia? So, of course, one of our most common culprits is corticosteroids. Steroids increase insulin resistance and hepatic glucose production, often leading to a significant hyperglycemia, especially postprandial elevations. Thiazide diuretics also raise glucose moderately, particularly if the patient is on a higher dose. Atypical antipsychotics are well known to increase weight and worsen insulin resistance, significantly raising the risk of hyperglycemia and even new onset diabetes. Our beta blockers, that's a little different. They don't directly raise glucose dramatically, but they can mask symptoms of hypoglycemia. So particularly tachycardia and tremor, which is clinically important in patients on insulin sulfonylureas. Even common over-the-counter medications like decongestants can transiently increase glucose due to sympathetic stimulation. So the key clinical point is when a patient's glycemic control worsens unexpectedly, you want to review the medication list before escalating your diabetes therapy. Sometimes the right answer isn't just adding insulin, it's identifying another medication that could be disrupting control. So when you're choosing therapy for these patients, you're going to think about multiple different things. So how high is the patient's A1C? Do we have any heart risk, kidney risk? Is there a risk for hypoglycemia? So is the patient elderly? Does the patient have a weight loss goal, or would losing weight potentially improve their clinical presentation? What is their renal function? And then what is the cost of the medication, and can the patient access that medication? So, of course, this is not a one size fits all. We have to consider lifespan and special populations. So, older adults, the primary goal for elderly patients is avoiding hypoglycemia. So, that means being very cautious with hypoglycemia prone medications like insulin and sulfonylureas. Targets may be less stringent, as we said at the beginning, especially in frail patients or those with limited life expectancy. So patients with renal disease, medication choice and dosing is going to become critical. So metformin must be dose adjusted and avoided if eGFR falls below 30. SGLT2 inhibitors lose efficacy in severe renal impairment, so they may be contraindicated depending on the patient's kidney function. So our renal status has to be reviewed before we're prescribing and then periodically thereafter. For pregnancy, insulin is the preferred agent. Many oral and non-insulin injectable agents are not recommended due to limited safety data, but we know that insulin allows for tight control and it has an established safety profile in pregnancy. Patients with low health literacy, so we have to make sure to simplify regimens whenever possible. Complex basal insulin may not be appropriate if the patient cannot safely manage the dosing, so clear instructions, demonstration, and teach back is essential. Okay, and finally, let's review some of our clinical algorithms, safety, patient education, and documentation requirements. So now that we have covered all of our medication options, let's bring it all together with a simplified ADA algorithm for type 2 diabetes. Step 1 is lifestyle modification plus metformin unless it is contraindicated. That remains the foundation of therapy for most patients. If additional therapy is needed, we don't just randomly add medications, we choose based on comorbidities. So if a patient has ASCVD or high cardiovascular risk, we add a GLP-1 receptor agonist or an SGLT2 inhibitor with the proven cardiovascular benefit. If a patient has heart failure, SGLT2 inhibitors are preferred. If a patient has chronic kidney disease, SGLT2 inhibitors are again preferred, or a GLP-1 receptor agonist if an SGLT2 inhibitor is not tolerated. If A1C remains above goal despite appropriate selection, we move to combination therapy. So we start layering agents with complementary mechanisms. And if patients present with severe hyperglycemia, significant symptoms, very high A1C, then we initiate insulin rather than slowly stepping through these oral agents. So our modern diabetes management is no longer linear. It is comorbidity driven, and it's focused on organ protection. Okay, so what are our insulin intensification strategies? So if a patient's on basal insulin, but that is not enough, then we have a structured intensification approach. The first step is always to ask, is fasting glucose controlled? If fasting glucose is still elevated, we adjust basal insulin first. There is no reason to add prandial therapy if basal isn't optimized. If fasting glucose is at goal, but A1C remains elevated, that suggests postprandial hyperglycemia. At that point, we have two main options. Preferred in many cases is adding a GLP-1 receptor agonist before starting mealtime insulin. GLP-1 therapy improves postprandial control, promotes weight loss, has lower hypoglycemic risk compared to adding a rapid-acting insulin. Alternately, we can add a prandial insulin with the largest meal, often called a basal plus strategy. This is a stepwise way to address meal spikes without immediately committing to full basal bolus therapy. If needed beyond that, we progress to basal bolus insulin, adding rapid-acting insulin before multiple meals. So the key clinical pearl here that is important is adding a GLP-1 receptor agonist before prandial insulin often results in less weight gain, less hypoglycemia, and a simpler regimen, which improves our adherence and our safety. So fix your fasting first. If A1C is still high, the problem is usually post-meal glucose. Add GLP-1 therapy is often the smartest next step. When starting basal insulin in primary care, simplicity is usually the key. So a typical starting dose is 10 units nightly or weight-based at 0.1 to 0.2 units per kilogram per day. Either approach is acceptable and is commonly used. After initiating treatment, titration is based on the fasting glucose because basal insulin primarily targets hepatic glucose output overnight. A common and safe titration strategy is to increase by 2 units every 3 to 4 days until fasting glucose is within the goal range. Again, typically that range is 80 to 100 milligrams per deciliter per the ADA targets. And that pace is going to matter. So if you titrate too aggressively, you increase the risk of hypoglycemia, especially overnight. And early hypoglycemia has consequences beyond physiology. It erodes the patient confidence and trust in taking their insulin therapy. So patients who experience early hypoglycemia often become very fearful and resistant to future dose adjustments. So slow, steady titration builds safety and trust. Fast titration builds hypoglycemia and patient anxiety. So a quick summary slide of the weight effects of diabetes medication. So weight gain, insulin, sulfonylureas, and TZDs. Weight neutral, metformin, although there may be a slight benefit, and DPP4 inhibitors. Weight loss, GLP-1 receptor agonist, and SGLT2 inhibitors. Cardiovascular and renal protection. So this slide represents one of the biggest paradigm shifts in diabetes care over the past decade. We now have strong evidence that certain diabetes medications can provide cardiovascular and renal protection independent of their glucose-lowering effects. So for patients with established atherosclerotic cardiovascular disease, GLP-1 receptor agonists have demonstrated reduction in major adverse cardiovascular events. For patients with heart failure or chronic kidney disease, SGLT2 inhibitors have shown significant benefit, including reduced heart failure hospitalizations and slowed progression of chronic kidney disease. And the critical point is that these benefits occur independent of A1C lowering. That means that we may choose a GLP-1 receptor agonist or a SGLT2 inhibitor, not just because of the glucose number, but because of the patient's comorbidities. This, again, is a major shift. Diabetes treatment is no longer solely about lowering A1C. It is about protecting organs and improving long-term outcomes. So when you see an ASCVD, heart failure, or chronic kidney disease in a patient with type 2 diabetes, your medication choice should reflect organ protection, not just glucose control. So some of the big patient education themes we have to be aware of are medication timing with meals, so making sure the patient understands when they need to take their medication based on how that mechanism of action is going to work, hypoglycemia recognition, injection technique, sick day rules, and adherence strategies. So recognizing who is at risk for hypoglycemia. So our high-risk patients, again, are our elderly patients, those with chronic kidney disease, patients that are eating meals irregularly, not on a regular schedule, anyone with polypharmacy, and then insulin and a sulfonylurea simultaneously. Our lower risk is going to be our metformin, our GLP-1 receptor agonist, DPP4 inhibitors, and our SGLT2 inhibitors. So let's review our injection technique education. So first, site rotation is essential. Patients should rotate within and between recommended subcutaneous sites, typically the abdomen, the thigh, and the upper arms. Repeated injections in the same location will lead to that lipohypertrophy, which causes erratic absorption and unpredictable glucose readings. Second, they need to review you have to review with them how to dispose of their needles. They should be placed in a proper sharps container, not thrown loosely into the household trash. That's a safety and a public health issue. Emphasizing pen priming. So patients have to prime the insulin pen before each injection to ensure that the device is delivering the correct dose and to clear air from the needle. Skipping this can cause underdosing. Again, avoiding lipohypertrophy cannot be overstated. The patient has to, if they have these unexplained variabilities in glucose readings, it is likely because they are injecting in the same site. So when insulin isn't working, assess the technique before escalating the dose. So let's clarify a little bit what the 6-day rules and 6-day management means. First and foremost, never stop basal insulin, especially in type 1 diabetes. Even if the patient is not eating, the body continues to produce glucose and ketones. Stopping basal insulin can rapidly lead to DKA. Patients will need to check glucose more frequently when they are ill, typically every 4 hours or more often if the level is unstable. If glucose is persistently above 250, patients should check their ketones also. The presence of ketones indicates insulin deficiency and possibly progression toward DKA. Patients can have a home kit urine dipstick that they can use. Hydration is, of course, critical, so patients have to stay hydrated, ideally with fluids containing carbohydrates if they are not eating solid food, and they should be instructed to call the provider if they're having persistent vomiting, positive ketones, inability to keep fluids down, or worsening hyperglycemia as they're checking more frequently. It is very important to teach your patients about this. Many DKA admissions occur because the patient stops their insulin when they're sick. They assume that if they are not eating, they do not need the insulin, and that is incorrect and very dangerous. So during illness, insulin needs often may increase rather than decrease. So of course, our best pharmacological plan can mean nothing if the patient cannot access or accept it. There are some significant barriers that exist in diabetes care. So the cost of GLP-1 receptor agonist and SGLT2 inhibitors can be quite prohibitive. Even with insurance, the copays can be quite high. Many insurance formularies determine what patients can actually receive, so sometimes forcing substitutions that may not align perfectly with the guidelines that we discussed. There's also injection fear, especially when starting insulin or a GLP-1 receptor agonist. That fear is real and should be addressed directly, but may need to be adjusted in the plan. And then, of course, we have to respect the cultural beliefs and the health literacy that influences how our patients perceive chronic illness and medications. So what are some of our strategies? Try to share in the decision making with your patient, engage the patient in the choice. Anytime possible, utilize assistance programs that may be available. Simplify your dosing whenever possible. The simpler the regimen, the improved adherence and reduced errors. Our effective management is, again, not just pharmacology, it is partnership with the patient, ensuring the access and the trust. We've seen this before, but just to remind that any documentation has to include indication, class rationale, dose and titration if indicated, education provided to the patient, your monitoring plan, and the follow-up interval when you plan to see the patient back. So a poor documentation would just be to write started insulin. A good and clear documentation would say started insulin glargine, 10 units nightly for uncontrolled type 2 diabetes, A1C is 9.8, reviewed injection technique, hypoglycemia recognition, and 6-day rules, follow up in 2 weeks. So a reminder that diabetes management is never a solo effort, is always a team-based approach. So we collaborate closely with diabetes educators. So they're going to provide some of that in-depth training on glucose monitoring, insulin administration, and lifestyle management, and their role is critical for patient empowerment. Our pharmacists, of course, are invaluable, especially with medication reconciliation and insurance navigation, if you need dose adjustments. Dietitians are going to be very helpful with your nutritional counseling, carbohydrate awareness, weight management strategies. Our pharmacotherapy is definitely going to work best when we pair it with dietary understanding. And for complex cases such as refractory hyperglycemia, recurrent hypoglycemia, insulin pump management, often we will involve endocrinology. So the most effective diabetes care happens when we leverage the strengths of the entire care team, of course. good outcomes rarely are the result of one primary care provider alone. So in summary, make sure that you are individualizing your A1C goals, follow those ADA algorithms, especially based on patient comorbidities, know the differences in the insulin, prioritize safety, and as we said, lots of patient education and clear documentation.